a sickness shall exist, there will be a duty imposed upon us. And for those of us that have chosen to be a part of the Queen's Ohana, these are words that can resonate in our heart. This is what it's about. This is what it's really about. So, mahalo. Mahalo. Eo, ai.
I'm gonna shift gears a little bit, and I know that this is probably the burning question in everyone's mind, which is one of the primary reasons why I asked Janice to come today. So again, Janice, what do you do in your work, and how does that affect our Native Hawaiians?
I think we've heard a lot about our mission, and Queens definitely has a sense of mission, and that's caring for people. In the finance world, we have this saying, no money, no mission. And so to achieve our mission, we have to have some money. And that's my department. We're billing the claims onto the insurance companies, and we're sending bills to patients. But we don't always do that because people don't have money to pay, but need services. They end up in ER. So Queens has what we call a discounted care policy. And under the Affordable Care Act, people call it Obamacare, of 2010, that act made it law that hospitals have to have a discounted care policy. Prior to that act, it was pretty much optional and hospitals didn't have to. But that act now requires that you actually have to have a written policy. Now, Queens has had this policy for more than 20 years. And prior to that, it was actually in practice, but not in writing. And what our discounted care policy is based on income or assets, you can have a discount for care if you are uninsured. And that discount could be up to 100% of services. So we are giving free care. It's totally based on income and assets. But I can tell you that we work with a lot of Native Hawaiian people, the people who don't have insurance. And along those lines too, when the person comes in, the front end, the patient access departments are trying to qualify, work with the person and qualify them for some type of insurances. And there's lots of different insurances out there. Low income is probably the most likely plan you'll get is Medicaid or one of the plus ones. But if you don't qualify, then my department is going to follow the patient access department and work with people to get the form filled out, to get us the documentation, verification forms we need. We recently worked with a man who didn't have any insurance. He's on Social Security disability, and he needed dental services. He had a couple of heart problems, and they traced it to his teeth, and so he needs to have dental work. So and this is like in the span of 2 weeks. He filled out the forms, he gave us everything we need, we coordinated with the dental clinic, we qualified him, and he's scheduled to have services. So a real success story. So we have a lot of that. I think our biggest problem in that is people don't want to go through the process. It definitely is a paperwork process. We need some information, and you may ask, well, it doesn't work. How can I give you any income verification? There's people out there who haven't worked for years. And what we ask people to do is give us a statement. Where do you live? How are you supported? Who's involved in your life? And we find that people really share a lot. And these are the ones who need the most help. Because, and a lot of people too, they want the care and they know they need it, but they don't want to come in because they don't have the money to pay. So we're reaching out through them, starting with the patient access. Most of the time it's through emergency, but like this person we just worked with, he knew he needed the care, but he didn't have it.
And I think to add what Janice was talking about, like with my program, I'm always looking for grant services that can help these people, especially the Native Hawaiians, because we know that they need care and they avoid it because of the cost, or there's a dignity factor, like I don't want to go in there and tell them I cannot pay. So I'm looking for grants that will pay for genetic testing, that will pay to fly from Molokai to Queens to get breast
oncology patients, the copay that the insurance is really high. And especially when you're having all those drugs week after week. So one of the programs or processes we're trying to roll out, and last month we met with a drug vendor. Most of the larger drug companies have copay health programs now. So what we're doing is we're searching our database for people who are accessing those drugs, and then we're going to give the names to the cancer center and ask them to register these people so that once they access services again, the copay on the drugs could be reduced by 75%.
That is great.
Yeah, so that one is really exciting. Talking to this drug vendor was really interesting, and he's saying most of the other drug companies have these kind of programs out there.
They're just not well advertised, though?
I had not heard of it before.
I've never heard of them.
It's a combination, I think, of encouraging people to kind of educate themselves about what is available, because when it comes to grant money, and I'm really happy that Rocky brought this up, is a lot of times the number one thing that will get asked from a grant is advertising and marketing, is getting that word out. So a lot of times we'll receive funding, we'll have the monies and the resources that could help, but then there is no funding or resource to say, hey folks, this is what we actually have. So when we do receive those types of monies, and these monies come in and allow me to, and my, the communications team to get out there and put the word out, we really just try to educate folks on getting out there, knowing their bodies, communicating very well with their doctors, and finding out what is out there, and kind of making it a kuleana amongst each other, and then to share what you find out, to share the resources with each other. And so from an oncologist perspective, as you shared earlier, the cost is so high. And so one of the things that we're able to help with the MCCP is helping on the cost of transportation to and from appointments. We've also, in oncology, have a survivorship program where a lot of times our patients who are on Molokai General Hospital, we don't have oncologists there. And so what we do is we set up teleconferences to, at least there's some type of connection with our patients there, and we can be in the medical center at home. Now, if patients do need help, though, as Rocky mentioned, we do have resource advocates and patient navigators who can circumvent and help navigate treatment on the long.
Mahalo. So I think, for you all who are not at Queens, you can see the very big variety, right? Healthcare is this huge beast in some ways that is so hard to navigate. And while we have the clinical expertise on one side, we have the operational expertise too. And so trying to find ways to bridge the two are always difficult. And when you come into the hospital as a patient, you get stuck between those two worlds. And so your healthcare decisions are made on, what is the best treatment, and can I afford it, or what can I afford it? So those are always things that are often in competition, but hopefully as we move forward with the Affordable Care Act, that will become a little bit more seamless.
Well, even if you have insurance, you could have a bill with a really large copay.
Yes.
And
If you're
so,
20% copay and your bill is hundreds of thousands of dollars,
or even a $2,000 copay. If
Yeah.
people aren't expecting this, they're not prepared to pay for it, and then they may be out of work for a while. So I always tell people, when you get our bill, call us. I've worked with people and said, if you're home, you're not going to be at work for a couple months, we're going to defer payment for 2 or 3 months. Call me when you're back at work. Or let's start you on a payment plan. Can you pay $50 a month? And then let's circle back in 5 or 6 months and see what we can do. We want to work with people, but the thing is, don't ignore us. Work with us, and we can work something out.
Thank you for doing that.
Yeah.
Yes.
That's awesome.
Okay, so I'm gonna also, we have a couple other people to hear from, and what I wanted to also kind of shift the session is to look at how we kind of got to our position. So all of us and every woman has
knowledge that needs to put it up. And I think, the struggles as an organization is to be able to offer those sort of traditional services to our people. You know, I don't know that we're at that point, but we need to get to that point. It shouldn't be a question of whether we can offer la'o, whether we can offer lomini. That should be a given service that we're able to provide.
Yeah, I got that. That's my department.
Duly noted.
There you go. Mahalo. Okay, and then the same question for you, Jamie, because I know you have a really provocative story.
Oh my, okay. So my story, I know as a child I enjoyed helping others. I just got a natural high off of helping others. But for most of my childhood, I had planned to do something within the arts. If it wasn't dance, it eventually became architectural design. I loved math, I loved drawing, and I geared myself towards that pathway. And everything changed on, you know the date, where I was, October 9th, 1992. It was the day after I gave birth to my daughter. I was 16 years old when I gave birth to her. And up until that point, I knew I was going to go into design, but for 24 hours straight, I just watched the role of a nurse. And I didn't know about nursing. I had no one in my family in nursing, and I was so inspired by their roles. I saw them wear so many different hats. I knew they were the gatekeeper to my care. I knew they guided the physicians about what was going on with me. They were my educator. They were my shoulder to lean on. Being 16 and being a parent was very hard, and so I was frightened. I was so scared. And I got to see the different hats my nurses wore in just 24 hours span. The next day, so I gave birth on the 8th, it was on the 9th, and that was something that I came up with through my frustrations as a staff nurse. I designed that, and I came in, that was something I wanted as part of my new role as a leader, and after 6 years or 5 years of that, I wanted more, and found myself in the role of nurse manager. And so I've been in this role for a year now, and I now get to fully embrace an entire unit in all the roles, and I often find myself on weekends asking, what am I doing in this role? Who put me here? How am I responsible for a budget that spans several millions? I am responsible for the clinical practice of 60 individuals, and am I the right person? I always ask myself, am I the right person to do this? And I spend a lot of self-time just thinking about what am I doing? Am I in alignment with the mission? Am I proud of my work? And every patient in every bed is my parent, and I drive our care based on that. If it's not good enough for my parents, then it's not good enough for anyone else. And I find that it's been a successful approach to changing and transforming our quality. And of course, eventually I aspire to work at a director's level or higher. That's a passion of mine, but I feel like I've got to get this down first, and I've got to understand the front line and how they think. And if I can do this, then of course when I move on, then I think I'll be able to impact through my leaders.
So I think, you know, all of us, I mean, we could spend hours talking about it, but to show I think the breadth and the depth of the women that work at Queens was what I kind of wanted to highlight, whether it be in our distinct roles as professionals, as managers, and some of the things I heard was that, yes, having the option and the kuleana of being a manager, you really do have that opportunity to make a difference, to make a change. And what I think I really love about this is that we're women, you know, and we're Native Hawaiian women with the best interest of Queen Emma in And yes, there are people at Queens that don't always see eye to eye with that in the same way that I think we do. Because I mean, to me, this is a very safe group of women here, and also very unique because we are spread far and thin throughout the hospital. But there are elements within each of us that we can impart on our own units. And so when we have one, we've got 8 units right here, and we can start with those 8. When we start transforming them, then we start to impact the other units, and pretty soon it's the entire hospital, all the way to Molokai, perhaps even all the way to West Oahu. So to me, it's so awesome to see all of you guys in your roles and how we help each other, because I know I cannot address Native Hawaiian health alone. Some people may see my unit as, okay, Diane is the go-to unit for whatever is Hawaiian, but I'm trying to show people that no, I am just the conduit to all of these other departments and units that have the same mindset and the same mission and the same intent that Queen Emalani and King Kamehameha would have. It's just in a different specialty, and so that's what I kind of wanted to throw out today. And as we start to close up the session, I did want to give everybody kind of their last, I don't know, aloha, farewell, or like a last parting thought, ho'omana'o for everybody to take home with them. I don't know if anybody wants to start first. It's just kind of free for all.
Can we do one word?
Yeah, one word. One word or a sentence or
Imua.
pardon.
Yes. Persevere.
Persevere. Omo. I.
Kua.
Kokua. I. Yeah. Taking care. Kako. Also support.
Stay committed to have faith in what you believe in, so that you can continue to go forward and take care of your community and go forward.
Ultimately, our this year's heritage message of Kuhinapapa.
Burden, responsibility, but privilege.
I don't know if I have one word, but I have one olelo no'ea that was shared to me by my kumu, and I think it's words that resonate in all of our lives, no matter what we choose to do, that we have a greater influence than we will ever have maybe of control of something, and that alone is powerful. But she shared this olelo no'ea that said, "A'ohe hana nui ke alu ia," and no task is too big when done together by all. And this is just one example by the women sitting in this room for the work that we do, and knowing that it's not about us, but it's the lives of the people of Hawaii that we do what we do, and we do it together, and that to me is powerful.
Mahalo. Oya maleno. Thank you, ladies. I'm gonna moderate, and I know that we have a diverse audience here. But I really wanted to thank each of the members of the panel that I invited. So we are all Queens employees, and we all have a role to play in addressing Native Hawaiian health. And what I'd like to do is to have everybody introduce themselves, your position within the organization, and the department that you work in. So I'll begin. I'm Diane Paloma. I'm the director of the Native Hawaiian Health Program, and so my department is the Native Hawaiian Health Program. Profound. Yeah, let's start on this side.
I'm Janice Spencer. My position is Manager, Business Services and Patient Accounting. I've been in Queens 13 years. My department is Business Services. You might not know what that is, but in the healthcare world, that's the billing department that handles the billings and claims and payments.
Hello everyone,
Marimula Tolentino. I am a training and development specialist, and I am part of the Human Resources Ohana.
Aloha, my name is Jamie Ka'alakahi'imana. I am the nurse manager for Med-Surg Telemetry Unit at Queens Medical Center.
Aloha, I'm Nicole Akana. I'm the Clinical Ops Manager for TAR 10 Maternity Services.
This is our brave participant.
Punahele Alcon from Molokai General Hospital. I'm the manager of the Women's Health Center, and I also work in administration.
And I'm Rocky Lee. I'm the manager of the Women's Health Center, and I've been in Queens 27 years.
And aloha everyone, my name is Roz Makaula. I'm the communications administrator for Queens National Cancer Institute's Community Cancer Centers program. I love saying that mouthful, but usually when we talk about it, we just say Queens and Triple C.
Okay, so I have prepared a couple of questions, and I did give our panelists the questions prior, so I do have a kind of like a preset, I guess, notion of who's going to answer what questions. So I basically have 2 questions, and then we'll open it up to people if you have any burning desires for any of us. But really, it was an opportunity for also us to get together because we all work in our own individual departments, and while I do interact with most of you guys, that's how I work with each of you, but I don't work with all of you guys at the same time. So this is, I think, a really good time to make some bridges and to also, for myself, to know that there are other Native Hawaiian women working at Queens, and we all have the best intent for our Native Hawaiian population, whether it be on Oahu or Molokai or even Big Island, Kauai, Maui, whatever. So my first question is, how do you carry out our mission, Queen's mission, to Native Hawaiians in your work? And let me start with Roz.
Okay. One of the things that I get to do in my job at Queens is always creating new materials, new information, educational resources for Hawaii's disparate populations, and of course Native Hawaiians are part of that population. So my main goal with the NCCC program and oncology services at Queens is to develop culturally sensitive information and materials so that when Native Hawaiian patients come to Queens or when we visit or talk to Native Hawaiians out in the community at our various health centers across the state, that when they pick up a brochure or they pick up whatever the resource tool might be, they can identify with the words there, with the people or pictures that they see, that they can see themselves, their loved ones, and it's from a place that we think if we make that connection, then it now opens them up, it opens up themselves to just learning more about why it's so important to take care of our health and lives. One of the other things we've done with the NCCP is we've created what's called a community advisory group, and this group is aloha. The community advisory group is made up of business and health leaders in Hawaii. And what we do is we utilize this group to tell us, there are eyes and our ears in the community. So the resource tools that we're developing, do they make sense? Are they culturally sensitive? Are they going to, hit upon the target groups that we want to hit upon? And what's really nice is Diane is a part of this community advisory group, so she lends a lot of her input on that one. And again, we have partners in health from Papa Olulukweki, from Emalani, from the American Cancer Society as well, and also from Papa Kolea community group as well. So it's a nice group that makes it the community advisory group.
And then Rocky?
So as the women's health manager, I am honored to be out in the community representing Queens. I go to many health fairs. I think last year we did about 30 health fairs, and that would include all the other islands that we visited. And one of the messages that we are trying to get out there is women's health is important. And I think we have several grants that we can offer to Native Hawaiians, such as free mammogram, free pap smears if they're underinsured or not insured at all. And we go out there and we're spreading the word about early detection and what health things you should be screening yourself for throughout your life cycle. So we're talking about inoculations, we're talking about checking for diabetes, getting physicals regularly. But the main thing is I go out with the boobs, I do breast self-exams, I show them how to feed it up, I say find the lump, I give them cards, I tell them how to
Find the what?
Find the lumps.
Oh, the lumps
in the
Find the
boobs.
lumps.
And I like those health fairs because the whole family comes, not just a woman. The husband or the boyfriend is following along, the children, the cousins. And I teach all of them. I even get the males involved. I tell them, males can't find lumps more than women because they're the ones, massaging the boobs. And we make it fun and try not to make it so intimidating. And we tell them how important it is because you can't survive from breast cancer. You can't be a survivor from breast cancer. Some of the other things that we do is we hold health classes at the Women's Center on a regular basis about all kinds of topics from skin cancer to diet to heart. And we're always looking for teachers. So when I'm out in the community and I need a lomi specialist or I need some other practitioner, I ask them if they're interested in coming to Queens. Some projects I got in the works right now is hula aerobics, thinking that that might be a fun way to get people into an exercise program. I also support our employees. We do employee hula. I'm looking for an ukulele teacher for our employees because I want them to embrace that culture of the Queens and the mission. So we're doing a lot, and I'm always open to people calling me, giving them ideas, and I think that's the fun part of the job is that I have that opportunity to bring new things in if I can, and people can contact me and get to know me, and I try to bring that to things.
Goes out with the boobs.
Yeah.
My husband found mine.
See? So it happens. It really does happen.
Luckily, it was benign, but I mean, yeah. So,
They can.
Okay, so same question I'm gonna also ask Philly. What?
For me, I have the privilege and the honor of welcoming all of our new family members into our Ohana. And I think for me that's very important that from the very beginning that we set a very clear picture about what is our kuleana. It's just not the jobs in which we were hired to perform, but also a clear understanding that it's a privilege to be a part of this legacy, and understanding that it's inclusive of not just the work that we do, but how we choose to do that work. And in addition to that, I do staff development, and I thank the Nurse Manager Council because they themselves had talked about creating a culture of accountability and assuring that we were all speaking the same language or having the same understanding of what is accountability and what is the role that we play in that. And so mahalo to the Nurse Manager Council because now I have a wonderful opportunity to meet with all the staff and we have great conversations about the experiences that we've had and what happened with it and what we can do to self-correct. And recognizing that we have many opportunities before it gets to a place that we don't want it to go to, that we have opportunities to self-correct, or we have wonderful family members, peers to come and say, hey, you need some help? What's going on? And it's very reassuring to know that when you come to work that you have a great group of people that you can rely on, that you know that they got your backs because you know you got their backs. And I think that really, really sets a different flavor, a different kind of dance that I think we're all learning now in healthcare is that healthcare is evolving and there is what was yesterday may not be today and may not be tomorrow. So we all are learning how to dance and understanding that this legacy is ours to own. And for however long our journey is here, a day, a month, a week, a year, that whatever you do, whatever you put into it is what you're going to get out of it. So that's really has enriched my life for the past 30 years, and I'm just really happy to be sitting here with beautiful Native Hawaiian women and hearing what they do and how we continue to bring life to the mission and the vision of Queen Emma and Kamehameha. So, mahalo.
A very important role, of course, Keitra. You were there for my orientation, and that was probably the best and only orientation I had for any organization that I've ever worked for. So,
Yeah, and I have to say too that we get a lot of mainlanders coming to Queens that were recruited because no one locally could take those positions. And when they go to orientation, they're so impressed with how Felice presents the Queen's mission and our history. And I think they feel like part of the family. I think that Felice does a fabulous job with that. Because I hear it all the time from the new employees that, wow, that was an amazing activity.
I just wish that one day we could take all the employees to Mona. There was some mechanism. But it was
part of my kuleana is staff development. And one of the things we look at is it's about retention as well. So what are we doing to continue to keep the light glowing?
You hit it on the nail. Yeah.
What are we doing? Because we do great things every day, every moment. And part of our journey is how do you manage that moment, Jack? Because some days it's just a little bit newy than others. But how do you manage that moment? And that's what I encourage all of the new hires. And I tell them straight off, we're not unique. We're not any different than any other organization. We have challenges. We have wonderful times. But again, whatever you put into it is what you're going to get out of it. And if you're going to come in with a not-so-great attitude, then you're going to come out with a not-so-great attitude. So how do we keep the light burning? So one of the things we talked about was the places, or what we call Wahine, and how that has a great connection to our founders, but also to the work in which we do. The St. Andrew's Priory, the Keiki are our future. Why not get out there and educate them and malama them and try to decrease some of the percentages when we cannot, it's preventative. Early teen pregnancies, drugs. What are we doing that from a Keiki level? And then going out and looking at Mauna Ala and Hana Akamalama. This is our connection where we can reconnect to our founders, and they'll inspire us and just fill our hearts with aloha, because this is what it's about. When you choose a career in healthcare, I think our founder, Kamehameha, said it so well, if you could indulge me. He said that so long as sickness shall exist, there will be a duty imposed upon us. And for those of us that have chosen to be a part of the Queen's Ohana, these are words that can resonate in our hearts, because this is what it's about. This is what it's really about. So, mahalo. Mahalo. Eo ai.
I'm gonna shift gears a little bit, and I know that this is probably the burning question in everyone's mind, which is one of the primary reasons why I asked Janice to come today. So again, Janice, what do you do in your work, and how does that affect our Native life?
I think we've heard a lot about our mission, and Queens definitely has a sense of mission, and that's caring for people. In the finance world, we have this saying, no money, no mission.
Right.
And so to achieve our mission, we have to have some money. And that's my department. We're billing the claims out to the insurance companies, and we're sending bills to patients. But we don't always do that because people don't have money to pay, but need services. They end up in ER. So Queens has what we call a discounted care policy. And under the Affordable Care Act, a lot of people call it Obamacare, of 2010, that act made it law that hospitals have to have a discounted care policy. Prior to that act, it was pretty much optional and hospitals didn't have to, but that act now requires that you actually have to have a written policy. Now, Queens has had this policy for more than 20 years. And prior to that, it was actually in practice, but not in writing. And what our discounted care policy is based on income or assets, you can have a discount for care if you are uninsured. And that discount could be up to 100% of services. So we are giving free care. It's totally based on income and assets. But I can tell you that we work with a lot of Native Hawaiian people, the people who don't have insurance. And along those lines too, when the person comes in, the front end, the patient access departments are trying to qualify, work with the person and qualify them for some type of insurances. And there's lots of different insurances out there. Low income is probably the most likely plan you'll get is Medicaid or one of the Quest plans. But if you don't qualify, then my department is going to follow the patient access department and work with people to get the form filled out, to get us the documentation, verification forms we need. We recently worked with a man who didn't have any insurance. He's on Social Security disability and he needed dental services. He had a couple of heart problems and they traced it to his teeth, and so he needs to have dental work. And so and this is like in the span of 2 weeks. He filled out the forms, he gave us everything we need, we coordinated with the dental clinic, we qualified him, and he's scheduled to have services now. So a real success story.
Yes.
So we have a lot of that. I think our biggest problem in that is people don't want to go through the process. It definitely is a paperwork process. We need some information, and you may ask, well, he doesn't work. How can I give you any income verification? There's people out there who haven't worked for years. And what we ask people to do is give us a statement. Where do you live? How are you supported? Who's involved in your life? And we find that people really share a lot. And these are the ones who need the most help. Because, and a lot of people too, they want the care and they know they need it, but they don't want to come in because they don't have the money to pay. So we're reaching out through them, starting with the patient access. Most of the time it's through emergency, but like this person we just worked with, he knew he needed the care, but he didn't have the money to pay. So.
And I think to add what Janice is talking about, like with my program, I'm always looking for grant services that can help these people, especially the Native Hawaiians, because we know that they need care and they avoid it because of the cost, or there's a dignity factor, like I don't want to go in there and tell them I cannot pay. So I'm looking for grants that will pay for genetic testing, that will pay to fly from Molokai to Queens to get breast biopsy, that will pay for other services, and I'm always on that path of looking for funding that can help so that maybe they can bypass that if they had to, if a grant is available to offer the services. And I think in an oncology role with Roz and her group, because she's just one piece of the NHRPC, but finance is a big issue in oncology as well. And they have special navigators who just do financial counseling of the patient to look at what are the needs and where can we get resources to help them, because we want them to get care.
Yeah, because even patients who have insurance, if you're an oncology patient, the copay that the insurance assesses is really high. And especially when you're having all those drugs week after week. So one of the programs or processes we're trying to roll out, and last month we met with a drug vendor. Most of the larger drug companies have copay health programs now. So what we're doing is we're searching our database for people who are accessing those drugs, and then we're going to give the names to the cancer center and ask them to register these people so that once they access services again, the copay on the drugs could be reduced by 75%.
That is great.
Yeah. So that one is really exciting. Talking to this drug vendor was really interesting, and he's saying most of the other drug companies have these kind of programs out there.
Can I just it's not well advertised.
I had not heard of it before.
I've never heard of that.
It's a combination, I think, of encouraging people to try to educate themselves about what is available. Because when it comes to grant money, and I'm really happy that Rocky brought this up, is a lot of times the number one thing that will get asked from a grant is advertising and marketing, is getting that word out. So a lot of times we'll receive funding, we'll have the monies and the resources that could help, but then there is no funding or resource to say, hey folks, this is what we actually have. So when we do receive those types of monies and these monies come in and allow me to, and my, the communications team to get out there and put the word out, we really just try to educate folks on getting out there, knowing their bodies, communicating very well with their doctors, and finding out what is out there, and kind of making it a kuleana amongst each other, and then to share what you find out, to share the resources with each other. And so, from an oncology perspective, as you shared earlier, the cost is so high. So one of the things that we're able to help with the NCCC is helping on the cost of transportation to and from appointments. We've also, in oncology, have a survivorship program where a lot of times our patients who are on Molokai at Molokai General Hospital, we don't have oncologists there, and so what we do is we set up teleconferences to, at least there's some type of connection with our patients there and with the medical center. Now, if patients do need help, though, as Rocky mentioned, we do have resource advocates and patient navigators who can circumvent and help navigate treatment on.
Mahalo. So I think for you all who are not at Queens, you can see the very big variety. Right, healthcare is this huge beast in some ways that is so hard to navigate. And while we have the clinical expertise on one side, we have the operational expertise too. And so trying to find ways to bridge the two are always difficult. And when you come into the hospital as a patient, you get stuck between those two worlds. And so your healthcare decisions are made on, what is the best treatment and can I afford it, or what can I afford it? So those are always things that are often in a competition, but hopefully as we move forward with the Affordable Care Act, that will become a little bit more seamless.
Well, even if you have insurance, you could have a bill with a really large company.
Yes.
And
If you're
so,
20% copay and your bill is hundreds of thousands of dollars,
or even a $2,000 copay. If people aren't expecting this, they're not prepared to pay for it, and then they may be out of work for a while. So I always tell people, when you get our bill, call us. I've worked with people and said, at your home, you're not going to be at work for a couple months. We're going to defer payment for 2 or 3 months. Call me when you're back at work. Or let's start you on a payment plan. Can you pay $50 a month? And then let's circle back in 5 or 6 months and see what we can do. We want to work with people, but the thing is, don't ignore us. Work with us, and we can work something out.
Thank you for doing that.
Yeah.
Yes.
That's awesome.
Okay, so I'm gonna also, we have a couple other people to hear from, and what I wanted to also kind of shift the session is to look at how we kind of got to our position. So all of us and every woman has a story to tell on what got them to healthcare. And so let me start with some of your, what was the most significant event that pushed you towards healthcare?
Okay, so mine started 16 years ago. My original plan after graduating high school, I had a scholarship to be an environmental engineer. So I was supposed to have gone to Colorado State. And 2 weeks before I left, I found out I was pregnant. 17 years old, so put the brakes on. My 13-year-old brother at the time just started getting into ice. So my parents couldn't take my baby. So I didn't go to school, so I stayed home with her. Janice Kalani Pulia was the president of our hospital. Did my pregnancy test at the time because she was the head of the women's health center there, and she cried. The day she saw me, and she said, "Oh my God, your life is not over. You know, you can continue. So, you know, for 3 years I stayed home. I had my son, and I was on welfare. You know no money, breastfeeding your baby, you can't send a babysitter. And then I saw her one day, and she was like, "So what are you doing?" I said, "Well, I stay at home with him. I can go back to school. You know, after I can send him to preschool and stuff like that." So I sent him to preschool, and she just encouraged me every time that I saw her. She said, "Okay, you can do it. It's not the end of your life. You can do it." So I went to school. I got my accounting degree through the community college of Molokai, and I got into accounting in a local nonprofit where it just so happened she was the president of the board. But I never know. So I've been doing accounting, and I'm like, you know what? I don't like accounting. This is just not for me. So I went back to school, and I got my bachelor's. And just so happened, my friend that was working with me at that place said, "You know what? I think you should do something else since accounting will make you happy. Apply for this job at the hospital." So I applied for the job, not knowing it was in administration. I go to the interview, and there's Janice interviewing me, and I'm like, oh. So more nervous because that's the lady that did my pregnancy test, told me my life wasn't going to be over, and here I am interviewing to be her assistant. So I went through the interview and I got the job. So I started as her assistant, and then I got my bachelor's degree in business, and then we were going through turnover, and they needed somebody to be the interim manager of the Women's Health Center. So on August 8, 2008, she said, "Can you do it for 6 months?" And lo and behold, I'm the Women's Health Center manager today in the same place that I had my pregnancy test done and found out that I was pregnant. Now I'm running it, and now I get to go into the schools and teach all of the kids who are 17, 16, 15, 14. Abstinence is important, and if not abstinence, use condoms, do what you can, be responsible for yourself so that you can go out, get, the Pala to come back to Molokai so that you can make a difference. And you can be your own boss, and you can, determine what you want for your island. So that's basically what brought me to the Women's Health Center. I want to thank you.
We'll look back and we'll summarize. And I want two others to share their personal story.
Okay, so my story is a little interesting. So I was actually 17 as well. I actually ended up in a nurse's aid program in high school right before my senior year. And I completed a certification, not really knowing that nursing was my career path, although I knew that I wanted to be in a position of caring for people. I didn't know that nursing was going to be my course. In any case, I worked as a nurse's aide through school. I graduated from HP with my bachelor's, and while attending the bachelor's program, I applied for a scholarship, and it was an Native Hawaiian Healthcare Scholarship. So I was very fortunate to have my schooling paid for through this program. But part of that program also entailed giving back to the community. So you have to work for the Native Hawaiian community. So which I did. I worked for Kilomamu as their clinical coordinator for approximately, the commitment was 2, but I stayed on for 3 years. And so at that time, I was the clinical coordinator. I did a number of program coordination. I developed an outreach program for Native Hawaiian young moms, doing education in the community, and also just inspiring them, yes, that it's not the end of the world, that they can continue. So it was very rewarding at the time. And through that process, I went back, or I was also given the opportunity to learn traditional Hawaiian medicine through Papa Hawaii. And so that was very inspiring, I think, for me. And for me, that was the critical point for the decision that I really had to move forward for the betterment of the employees. So it wasn't about myself. It was my kuhina to move the lahui forward. So I know at the time that I was going to be moving to the mainland, and I went back to school. And my husband, of course, a lot of times when I say, "Oh, I'm not going to do it," that's not the course that I should be going on, or I'm always resistant to stuff. That seems to be the path that I should be going down. And so, in any case, I went back for my master's at UCLA. I graduated with my FNP and decided to come back because I knew Hawaii was where we would eventually raise our family. And so I did. Although I didn't work in the capacity as a FNP, I ended up doing maternity services because that's where my heart and desire is. And so I continued on that path as a frontline nurse just because it was an easier way to get a position. You can get a nursing job pretty much anywhere. And so that's what happened. And I continued on. I was given the opportunity to apply for the clinical ops manager position about a year ago, which I got, and I've been in that role ever since. So, as I shared earlier, there's a lot of struggles on the unit just because of leadership change and just different dynamics that's occurring on the unit. But truly, for me and my position is really that you have to, in order to make change, you have to be in certain positions. And I learned that early on through just different training and, like I said, that pinnacle point of learning under people. Why sort of just reaffirmed that this is my path. And so the journey that I take from here on, sometimes I may resist what's in front of me, but truly I know that there's a bigger path.
For those of you who are not familiar with Papa Henry Awai, he is seen as the one Kuhinapapa or Native Hawaiian medicinal expert who was one of the few who actually taught the practice and has a cadre of practitioners that follow in his place. And I do know that he got a lot of resistance from the community for teaching that practice. And when what an honor to be able to know him before he passed on and to know.
I can't thank him enough for the knowledge that he's imparted on me. And I think, the struggles as an organization is to be able to offer those sort of traditional services to our people. I don't know that we're at that point, but we need to get to that point. It shouldn't be a question of whether we can offer la'aulapa'au, whether we can offer lomi. That should be a given service that we're able to provide.
Yeah, I got down. That's my department. Duly noted.
There you go.
Mahalo. Okay, and then the same question for you, Jamie, because I know you have a really provocative story.
Okay. So my story, I know as a child I enjoyed helping others. I just got a natural high off of helping others. But for most of my childhood, I had planned to do something within the arts. If it wasn't dance, it eventually became architectural design. I loved math, I loved drawing, and I geared myself towards that pathway. And everything changed on, the date, I know where I was, October 9th, 1992. It was the day after I gave birth to my daughter. I was 16 years old when I gave birth to her. And up until that point, I knew I was going to go into design, but for 24 hours straight, I just watched the role of a nurse. And I didn't know about nurses. I had no one in my family in nursing, and I was so inspired by their roles. I saw them wear so many different hats. I knew they were the gatekeeper to my care. I knew they guided the physicians about what was going on with me, They were my educator. They were my shoulder to lean on. Being 16 and being a parent was very hard, and so I was frightened. I was so scared. And I got to see the different hats my nurses wore in just 24 hours span. The next day, so I gave birth on the 8th, it was on the 9th, I made up my mind in a moment. And I remember saying to my mom, I know what I'm going to be when I grow up. And before she could say anything, I said, I'm going to be a nurse. And I will never forget her response. And her response was, can you just get out of high school? Just get out of high school and we will talk about college. And I said, fine, but I'm just letting you know that's what I'm going to be. And I went back to school and I rearranged all my courses to line myself for nursing. When I got out of high school, my father was unemployed and my mother was in an internship. And if you know internship, that's minimum wage. And so when I went to them to say I want to go to college, they said to me, sorry, we can't help you. And I could have, admitted defeat at that point, and I didn't. And so I started to research what are my options. And I connected with an excellent counselor in my high school, and she lined me up for at least one financial need scholarship, which is Hana. I am forever indebted to them. They paid for my entire schooling so I could become a nurse, and other various scholarships. And so I was able to get it fully funded. I graduated with my bachelor's degree in nursing, and when I came out, and even at that time, my counselor tried to steer me from nursing because he said there were no jobs and I would risk having to leave the States. And the 2 years before that, those students were leaving the States. When I came out, he was right, there were jobs. And so I worked in the role of a nursing assistant for about a year. In hindsight, that was key. That was key. I needed to learn the role of an aide. I think when I became a nurse, it made me a stronger nurse. And my team dynamics with that group, I've always been strongly connected to nursing assistants because I walk their shoes. I was in the role of a nurse for 6 years, and I quickly became disheartened by my inability to impact a large volume. Caring for my 4-patient assignment wasn't good enough for me. I wanted to know that I could impact larger. And so I started to find myself getting involved in multiple leadership roles throughout the organization, and then that wasn't enough for me. So when the role for ops manager came up on my unit, it was a natural next step. And the moment I stepped in, I introduced something very non-traditional to nursing. And that's called the internship huddle. And as we know now, Nicole is housewife. And that was something that I came up with from my frustrations as a staff nurse. I designed that. And I came in, that was something I wanted as part of my new role as a leader. And after 6 years or 5 years of that, I wanted more. And found myself in the role of nurse manager. And so I've been in this role for a year now.